Welcome to Zodiac Exclusive. My name is John Paul Kayuni, and in the program today I'll be talking to Dr. TANIA Nkungura. She is an oral and maxillofacial surgeon based in the United States. She is also the co-founder of the Smiling Surgeons Incorporated, a non-profit making organization based in the US. Welcome to the program.
Yes.
Maybe before we go deep into the program, I just wanted to understand, what is it when they say maxillofacial or oral and maxillofacial surgery? What is it?
Oral and maxillofacial surgery is a specialty of dentistry. So in our training, first we go to dental school, and then beyond that, there's another 4 to 6 years of additional training, and for some, even beyond that, specializing in the care of not just teeth. In fact, most of our work, if we're looking at teeth, we're removing them, we're repositioning them, but we're not fixing them.
You're not fixing them?
No, we really take care of the whole face. So that means the jaws, the under the orbits. Sometimes people are in accidents and the whole face is fractured. So we work anywhere from the top of the forehead down to the face, and sometimes in the neck as well. Yeah.
And you said you start with the dental school,
yes,
and then you go the other side.
Yes, you specialize.
Okay. Now we understand there is a shortage of such specialists in Malawi.
Right.
I hear we only have one doctor, in an oral and maxillofacial surgeon in Malawi. How serious is that in a country like Malawi, having only one surgeon in that field?
Well, I think part of our challenges in Malawi stem to dentistry itself. It's been in the past, last year, Malawi graduated the first 10 dentists trained at KUHES. And so you cannot develop a specialist if you don't have graduates.
Okay.
So in a population of over 21 million people, one person cannot see and evaluate 21 million people in a lifetime. That means diseases, injuries go untreated, and they advance to where sometimes it can be life-threatening. And so I think that we have a huge crisis for lack of care. Yes.
Now, I want to understand, is it the time that it takes for one to complete the program that maybe makes people shun away from it, or is it, what is it really that is, because just having one surgeon of that kind in Malawi, what is it that is preventing a lot of people to join?
Well, I don't think it's a prevention. It does not exist. We do not have a training center here for oral and maxillofacial surgery. We've been training medical doctors for over 30 years. But just last year, the first dentist came out. And we've been independent for over 60 years. That means that it has not existed, dentistry itself, but oral and maxillofacial surgery, we have yet to build that as a specialty where we're training. So that means to establish that here, someone has to go outside of the country, which is what Dr. Mchenga did, but I don't believe he was sent.
Okay.
Yes.
Okay, so he did it for himself.
Yes.
Okay. Now we have quite a number of patients in Malawi. I just wanted to understand, How long do they have to wait until they get help?
Yeah. Now, how do you know that you need help? There are people who believe that mwina analodzedwa. So they see asinganga, they try this, they try that to the best of their knowledge. Many of us don't even know about this to know you need help. And so people wait a lifetime. When we are meeting people for care, the disease process has advanced for years. Yet they will tell you, oh, it started last week. No, it became unbearable last week.
Last week.
Yes.
But they have had it for a long time.
For too long, for years. And so the disease process arrives at an advanced state. But they don't know. How do you know where to go to? You do the best you can. If your area does not have an oral and maxillofacial surgeon, we already know that.
Yeah.
But if you don't even have a dentist, let's say you are in Elangeni, where my mom is from. Kuelangeni, there's not a dental clinic. Ojo Tamanu was my uncle helping people from pain, but he was not a dentist. And so people wait a long time because they don't know. We have a tremendous job of education. Currently, there are students in the pipeline for training, and maybe there are about 70 dentists in Malawi, and 70 to 21 million people, again, is lack of access. Just to contrast, what do I mean by that? In the United States, every child, before they go to school, has to have a clearance from a dentist to say, we saw them, this is the dental disease, they get x-rays, and then they can go to school.
Okay.
That is where we identify diseases early, at least from the beginning of school through 12th grade. After that, you kind of have to make sure you make that your habit. So many people go twice a year. The insurances tell you, oh, you get 2 cleanings. Oh, it's free, I don't pay, twice a year. And just to be clear, these things are not part of oral and maxillofacial surgery. These dentists who see people then make the referral.
Yes.
We're suspicious of this, please evaluate
Even
that.
even before the problem comes out.
Correct, correct. Things start to show before the person has pain, but you see it on x-rays, you know, unless it's an accident. Somebody's in a car accident, they go to the hospital, the face is broken, we get called to the hospital to manage that.
Okay.
Yeah, or somebody's growing, it's not a problem, but their face isn't aligning correctly. They see an orthodontist, another specialist who straightens the teeth and mouth, we fix that.
Okay.
Yeah, it's part of the healthcare system.
Now let's talk about one thing that you are in Malawi for this time around. You've come for a camp at Kamuzu Central Hospital, where you are assisting patients.
Yes.
Where did this idea come from?
Well, this is our 3rd camp, and the first at Kamuzu Central Hospital. So we're at Kamuzu Central Hospital because Queen Elizabeth Hospital in Blantyre has a constriction in access to the operating rooms. When we are occupying the operating rooms, other surgeons can't operate. So there was more space at Kamuzu Central Hospital, yes.
Okay. Now, I wanted to understand, where are you coming from? Why did you come up with that initiative in the first place?
The idea came, I would say, number one, from understanding we have a gap in care. Then tragedy struck when I lost my brother, who was also our manager of the practice that I have in Washington, D.C. After we buried him here in Malawi, and his name was Miko, we came the next year for Jiliza. And at that point, I could not imagine coming for Jiliza. My brother, my dad are gone. We've cried. We are still in pain. But how do you transform your pain to action? How do you give thanks? God, you've given us this opportunity. I have one colleague here, Dr. Mchenga, by himself. And my gift is my training, my hands, my head, my heart. So as I was speaking about this, Dr. Shelby Curtis, another oral and maxillofacial surgeon, was in training. She says, oh, I'd love to do a medical missionary trip to Africa. I've always wanted to do that. And as she started to share, we mobilized and asked Dr. Mchenga, is it possible we can help you?
Yes.
So it comes from helping. He was open, accommodating for us to join him in his work. Without the assistance of Madame Esme Chombo, Madame Ambassador, Justice Esme Chombo in the United States, really accompanying us, taking this initiative into places that I've never been, speaking to ministers of health and government officials, and even joining us on the wards, this would not have happened. So our desire to help and understanding the needs, and Dr. Mchenga, there was Dr. Chimimba, the willingness for them to say, here are our patients. Let's work together. Because in the United States, where I'm practicing, you don't see diseases this advanced. We don't know who the patients are. And when you come to help, you really want to help. You don't want to do your own thing. Yes.
Ngati ndikukumvani bwino, mukutanthauza kuti kapena mukuyankhula kuti mugwira ntchito imeneyi mwachifundo, charity. Correct. Without expecting anything in return.
Correct.
You are using your own resources into this.
Yes.
Mwina anthu kumangofuna kumva kuti inuyo you are based in the US.
Yes.
You are now in Malawi. Are you getting any assistance from anyone for this?
We have no financial support. In the sense that nobody pays us. I have shut down my practice, meaning that I'm not seeing patients while I'm gone. But I have staff answering phones, making appointments, working, who will get paid in this down period. My colleagues, Dr. Bryant, Dr. Longwe, who have bought their own tickets, are doing the same in their practices. Nobody bought the tickets for us. We have put that aside to say, let's help somebody else. What we hope to do, and when we're here, it's the kindness of the patriots who are working to help Malawians. Many of them are retirees who are working to make sure, are these people okay? How do we find out accommodation? The CUHES has supplied for us students who are here to join us. We were greeted by the Office of the President and Cabinet, who welcomed us. The Deputy Minister of Health, who's also a patriot, came to welcome us. But yet, the finances to say that we get paid or we make money from this is not there. But we have ambitions to gain attention, to say, look, we don't need the money, but it takes money to buy equipment. We've gotten donations of equipment through Project Cure. We have a vendor with us who is with Biomet, who has taken time out and donated Oh my gosh.
Now,
In Kwacha, lots of
that's a lot of money.
Yeah.
Komano, you've gathered patients from across the country, I gather.
Yes.
And you're keeping them somewhere, you're taking care of them for free. These patients are not paying anything.
They do not pay. They do not pay us for surgery. We do not charge for surgery, correct.
How many patients have you gathered this far?
Well, I understand our goal was to treat 50 patients. So there were about 25, 27 that came from Blantyre. There were another 20-something here. There were 5 that came from Zuzu. But these are the central hospitals, right? So that means they're coming from all over the country. And then people here. So they keep showing up to the hospital, and they are being housed at Kamuzu Central Hospital, yes.
Now, maybe what are the most common conditions that you are seeing in the patients that you are assisting this time around? Which conditions are coming out prominently?
Everything is advanced, let's say that. We are treating mostly pathology. Tumors. Yes, and most of those tumors are known as ameloblastomas. What is that? It's a tumor that arises out of the tissues that make teeth. So you have teeth, I have teeth, it can happen to either one of us. And it's grown so long that the jaw or the face will grow and not stop growing. And so, but there are other pathologies as well, other tumors, cysts, we've had some fractures, and so the range of commonality are people suffering and living with long-term pathology.
Mavuto ambiri amene mukuonawa ndioti amakhudzaso mwina munthu kuti their confidence when they meet others, issues of social interaction.
Correct. Identity.
Yes. How serious is that in the patients that you're seeing in terms of their social interaction and their confidence?
Right. This is very serious because it affects productivity. Normally, the patients are healthy, physically.
Yes.
But because they don't look the same, they don't get jobs. When we're hiring people, we want them to look a certain way. Maybe they can't speak that way. It can affect family life and interactions, depression, and a lack of contribution to society. Yet, we've seen when people get treated, they are grateful. And you find them saying, now I can work, now I'm ready. But the healing process is hard. When we do these surgeries, rehabilitation and healing takes time, but the goal is to return this person to a normal life as soon as possible. The challenge is, if somebody has had a disease for a long time, and so your treatment is to say, I need to take off your disease.
Yes.
But it's coming from this part of your jaw to this part. And the solution is to remove the entire jaw. And we put kachitsulo pamenepo.
Yes.
They still have another defect. How you eat, you're affected by that. You don't have the teeth to chew. So those still affect people, even though they look nice. You may not notice it or you see a scar, but they themselves don't feel the same. But compared to living with a disease that was not stopping, the gratitude is so far greater. And if we could catch them before the deformity, we can save teeth, we can prevent so many problems.
Yeah, because I was going to ask, apart from the social interaction, apart from the physical part of it, there is some psychological and emotional pain that these people feel. You are a doctor in this field. How does it feel, the patients that you've interacted with? This
kunoko when I see patients from the last camp and the camp before and the guardian, and I go to a ward and we have 3 beds, I can only take 3 people, 1 person at a time, and I'm leaving behind 15 in this ward, and each of them wants to come. Or you see, you know what, this time akuyanganika kuti awondako.
Yes.
Because they can't eat as well. And you see that they're pulled back or they're covering themselves. You know, the Bible says, I wish that everyone would have life and life abundantly. That's God's wish for us. Not some, everyone. And you see that your brother is suffering with that. I wish we could help everybody. So there's a part that says, we're not able to reach everybody. But there's a part that says, we're going to do this in order to help people. Yeah.
Do you think the health system in Malawian hospitals, obviously they are overwhelmed with these problems. Is there any hope of doing better in future?
Absolutely. Absolutely. And the challenge is, we don't depend only on one system. For example, in the United States, I don't work for the government, I work for myself. And there is governmental interactions through insurance that I'm able to help people. In Malawi, the notion that somebody who is trained at a certain age has to retire. And so they stop working, they're trained, they're sitting at home. But the notion that, hey, here's a skill set that we can now open another center. We have to be able to expand. When I was a child, when I left Malawi in high school age, well, I left at 6.
Okay.
Okay.
You left Malawi
I left
6.
Malawi at the age of 6.
Yeah.
Right? And then when I went to college, that's when I really stayed out. At the time that I was in school, in the 80s, but I'm only 25, right? In the 80s,
yes,
we had about 6 million people in Malawi. In my lifetime, Malawi has almost 4 times itself. Amadijani quadrupled in size,
yes.
But our schools aren't expanding. Our hospitals aren't expanding. By this time, we should have 4 Kamuzu Central hospitals in Lilongwe, minimum, maybe more, according to expansion. But we're still using the same infrastructures, yes. And it's hard to grow, but we need to continue to build. We must continue to train, and people may have to work longer training others. We can't just say, okay, Basban, until you retire, and you're out. Because the patients aren't getting seen. Yeah.
Let's go back to the camp that you're having at Kamuzu Central Hospital.
Yeah.
Mina camp imene mukumapeza bwanji ma patient oti muwathandize. What criteria are you using to identify these patients?
So my patient amabwera from the central hospitals as referral. So that means kuti mwina kuma district hospitals awo anali ndi vuto anachitidwa referral to their central hospital Mzuzu, Queen Elizabeth, Kamuzu Central. So from there they get channeled to Dr. Mchenga.
Okay.
So Dr. Mchenga has a list, it's growing. There are over 300 people on that list that need care.
Over 300?
Over 300, yes. And unfortunately, we think that it's only 300. But we started off saying, how do you know you need help? So that means that if we had to assess in the 21 million people in Malawi, there have to be more people that have this, but they come by referral.
Okay.
Yes, and from there, he selects those who are most advanced, or somebody has an infection. They were waiting on the list. Now it's infected. They can get sicker, that they can die from this infection. They move up. Somebody, we know they're in an accident, the bones are exposed, they move up. But we try to take care of the advanced diseases, meaning that the smaller diseases, which are easier to take care of, continue to grow.
Yes.
But we na kuvutika. So it's very hard to pick the criteria according to greatest need. Yeah.
50 patients that you targeted to assist during this camp.
Yes.
How many have you assisted this far?
This week we've treated 22 people. Our goal was, if we're doing 50 in 2 weeks, that means we need to do 25 each week.
Each week, yes.
So we're at 22 out of the 25. And one of the things that we realize is that I can say a number, but each condition is so different. You go into surgery, somebody was there for 8 hours, 10 hours. That means you don't have time to see the next patient. By the time you finish, the anesthesiologists are helping us. The nurses that are helping us also have to go home. And transportation is very difficult at night. And many come from far. So we have limitations with and we get tired.
Yeah.
Yes.
Yeah.
Yes.
How many on average in a day do you operate the patients?
There are 3 rooms operating. We're hoping to take care of 5 per day. Yeah.
Okay. Now, I understand some of the patients after you've assisted them, they still need. You mentioned it. They still need some psychological support. They still need rehabilitation.
Yeah.
Moving forward, these patients that you've assisted this far, what are they? What is it that you have in terms of assisting them, or how are they going to be assisted to recover fully after the operations?
When we treat them, one of the challenges that we answer is, if you are taking care of somebody, you operate and you go, that can be abandonment. We are operating. They are under the care of Dr. Mchenga. He's with us. He knows who has had what. We explain that to their districts and other community hospitals who may have dentists or dental therapists to help us. In terms of healing from the procedure, we can manage that. But the complete care of a patient, the social, physiological, some people require physical therapy to come back, but we need the entire system working in order for them to have those needs met.
Okay.
As oral and maxillofacial surgeons, we do the best we can, and we try to help, but we need a system to support that.
So what systems are in place maybe to ensure patient safety and proper post-operation care?
The systems in place to ensure safety in the patient's care actually start before they go to surgery. We do an assessment of blood pressure, health condition. Are they breathing okay? Are they already sick with an illness? If they are not stable for surgery, we get a medical consultation so that they can get seen by a medical doctor or pediatrician, gadali mwana. Anesthesia sees them to make sure that they're safe for anesthesia. Ma full blood count, kodi muntu uyu akupuma bwino, akukosomola, what can we do? Kenako. When we know that they're stable and safe, they proceed with surgery.
Okay.
Minor surgeries, we do the procedure, they go to sleep,
okay.
They wake up, they take out the breathing tube, they start recuperating on the ward.
Okay.
many of them have advanced need for support of the airway. So we already know we need ICU care after. I found out for the first time intensive care unit is known as Kwasirias.
Kwasirias.
Yeah. So we have to prepare the family to say, Ababa, when we remove this jaw, kupuma, kungakale compromised. So we plan ahead that this is to ensure safety and healing. It's not that there's a problem that they need to go there, but these procedures of removing parts of the jaw, the entire jaw, can affect airway access. So for their safety, we take long to take out the breathing tube until anesthesia says, no, they're fine. Then they take that out, they step down, and then they go to the wards for care.
And ndimafuna akamalizana kuti wodwala uja mwamuthandiza wachoka kuchipatala wapita kwawo akakhale bwanji kumene kuti pali china chilichonse mene mukuchita kuti mwina aonetsetse kuti akukhala ndi bwino chifukwa munthu ja it's like a complete change in your identity. You had all this thing here and you are changed. Akhale bwanji pali zina zimene mukuchita?
Pali zambiri. So tinapita kuchikwawa. And kuchikwawa kulikuwa dental. So ndikuwafunsa ma dental therapist. Kodi inuyo a dentist anu amene amakuthandizani because they work under a dentist. Ndi andani? Akuti Dr. Mchenga.
Okay.
So I said, well, has he been here? Akuti sitinaone. Dr. Mchenga is so busy at Queen Elizabeth Hospital. He cannot leave that clinic to go to Chikwawa to visit. But we train our colleagues in the districts, in the other hospitals, this is the care. And we also say to the patients, Mumvera after 2 weeks, Mumvera after 3 months. They call them to check Kodi mulibwanji, and we're educating them. But again, it's difficult. We had a lady who had surgery, and she's eating maheu, toba, para, and she says, ifeta zolowela nsima, sitikudya. So it is a big transformation on how you live after surgery. And we do the best we can. They find ways as well. Goma, it's not easy for the patients.
Now, this camp, is there something like Malawian doctors, surgeons benefiting, say, skills transfer during this camp?
Great question. We are not here only to treat. When we provide care, we have the first trained dentist from Malawi at the table with us. We have Dr. Now I'm going to get in trouble, Nsini. We have Dr. Ruth, Dr. Esther, and there are others. There are about 10 new dentists. We've had about half join us now. We have colleagues who were trained as dentists outside of Malawi, like Dr. Chikuni, Dr. Lungu, who are more active, Dr. Umu, who are also joining us at the theater. They get trained in using the instruments. Project Cure secured a special drill because how do we remove a jaw? You have to have equipment to cut and remove that drill. So Stryker is one of the companies that donated a drill. This drill stays here in Malawi, meaning that all these local dentists learn how to use the drills, the equipment, everything that we're using here stays here for them. So we believe in knowledge transfer. We will be successful not when the patient list is done, but when our Malawian colleagues don't need us. And we're just here to share other knowledge. So training is a big part. We want to build the capacity as much as possible.
Ntchito imene mukugwira munayamba nokha, you explained that, but now you have like other partners joining you. Mafuna ndingomvetsetsa kuti ubale wanu ndi ma partners amenewa ukuyenda bwanji, and any other plans in future maybe to continue having camps in Malawi, visiting, assisting patients?
Well, clarify for me the partners. Mugadima partners, we have a lot of partners. Boyambila on the ground. I left Malawi at the age of 6, meaning that I only know my family and friends of family. I'm in places that my family is not. Without the introduction to the Malawi initiatives by Madame Ambassador Jombo in the United States, where I met Malawians in the diaspora, led by Professor Mbewe, along with Malawians here on the ground who are helping us. And I say the patriots, but Honorable Kamuzu Juambo started it, along with Professor Maureen Jirwa. There are so many people, Honorable Chris Kangombe, that work in partnership to ensure that we are connected. We, through this Malawian relationship with the diaspora and the patriots, we get donations from Project Cure. And like our hospitals have been doing, we are requesting for assistance with drills so that we can get more. When we started off with Smiling Surgeons, we were ambitious. We want to be worldwide. We have the priority of Malawi, yes, but it is our dream that we work in other countries as well, because we know if Malawi is suffering, Mozambique,
yes,
Zambia, Bora, but there are other countries that don't have this access. So maybe we can become a training center. Maybe we can help bring others here for training as well, so that people can get help.
Nimafuna ndingodziwa somina this camp that you're having here. Some people say camps are only temporary. You assist the patients, yes, they get better, but palizina zimene zimazabweranso. Camps are only temporary. How do you respond to that?
This is the first time I'm hearing about that, and it's true. A camp is temporary. Madame Ambassador suggested that we create a center for excellence. That means that we need a structured place for training oral and maxillofacial surgeons. And that is not in the dental school, because Malawi needs strong dentists who are great at fixing teeth, replacing teeth, maintaining oral health. But beyond that, that specialty training is needed. The challenges of coming to different locations, it's nice, eh?
Yes.
We can go there, we provide care, but we rebuild from the beginning. So we need to get set up, understand things. If we had our own center, there's a staff, they know the patients come, they're on a schedule, you can organize it. People come together Wunji for 2 weeks. Some get treated, some don't. Come at a center, you have your appointment date, you can keep coming. But one Dr. Mjenga cannot do that by himself. A center requires anesthesiologists, other specialists, and this is treating a national program. So that government, that is the Ministry of Health, partnering with them to create a center that supports this care will help us take care of this problem now and prevent future advanced diseases. And so, yes, camps are temporary. The solutions take years and investment, and that's what our big dream is. If we can do that here, that would help. And then you find out that, you know what, one center for 21 million people is not enough. We need centers all through Malawi, yes.
Now, you mentioned kwa program, kunena kuti you are doing this for free.
Yes.
The patients are not paying anything.
Yes.
I wanted just to appreciate if you could quantify how much would be needed to treat a patient who presents with the conditions that you talked about, on average. How much would one spend on such treatment?
Well, that's a question I'm not a money person, so let me tell you how I heard it.
Okay.
In 2023, the Minister of Health, Dr. Kumbize, joined us. And we had the privilege of, she joined us to see the patients.
Yes.
And then she hosted a dinner for us. And at that dinner, she shared with me roughly about 40 to 50,000 US dollars are paid per patient to take their care outside of Malawi. A patient, then they need a guardian, and the travel abroad, and accommodation while they're healing. So the savings that we are providing by bringing care here, we can only do the maths on that. I don't know what that is. What we know is that Malawi is rich in resources. We have precursors for titanium. A lot of these plates and screws are made with titanium. We have engineers. Wouldn't it be nice to say, you know what, while we're doing surgery, rather than buying plates and screws from the United States or from America and shipping them to Malawi, fuel and everything, that's what makes things more expensive. But we can make them here. What does that mean? We're employing people, we're hiring them, we're building industry. We can use them here. We can export them to our neighbors. And therefore we are creating an economy that has something to offer. Rather than taking the raw material out, we can do it here. Malawians are smart. We have resources. We just haven't had the opportunity to think, what can we do for ourselves right now? Many are, but I think we have to do it urgently and not say, well, what can we do?
So during this camp, are you getting any support from, say, individuals, organizations?
Yes, we are. Now, this camp is hosted in Lilongwe. There is a team from Blantyre consisting of students and dentists alike who have joined Dr. Mchenga here. That means that, number one, accommodation. We have to be housed somewhere. So National Bank has been a sponsor of all our camps. They are supporting by funding. We are at the Sunbird Lilongwe Hotel, and they've been great hosts. There's Umodzi Park that's housing us. Kamuzu Central Hospital itself has also been a great sponsor to our students. We are getting meals. But what has been most striking to me is that we're doing an internal or external fundraiser. And we've received donations of 5,000 kwacha, 10,000, 100,000, millions of makwacha in donations. Some people have sent eggs to feed the camp, and some of that goes to patients and to the guardians. We are receiving bananas, batata, and so there's a great interest. And these donors aren't only in Malawi. We've received donations from people in the United States. I've seen Canada. And as I look at this list, I am humbled because the majority of these people are people I don't even know are aware of what's going on. And so we're getting a lot of support.
You talked about kupereka thandizo limene kwa ulere. The patients are not paying anything.
Correct.
Are you getting any support from the government in this?
The patients, you're right, the patients do not pay. And in terms of government support for our team that's here to provide these free services, we've heard that the Minister of Health is interested in the work we're doing. We have yet to meet with them. I understand she was traveling in Geneva, and then we're always in the operating room. But as of yet, we have not interacted one-on-one with the government in that fashion.
Do you need support from the government?
Absolutely. I think that when you have your government behind you helping out, it alleviates this care being burdened by retirees or small businesses. We are treating a national health problem. I think that the government should be involved as well in this care, and perhaps even leading the work we're doing so that we can encourage and bring other people. In the United States, I have the president of the American Association of Oral and Maxillofacial Surgeons, who has over 9,000 surgeons. It would be something to say, let's bring this president to meet our leaders here in government, and what can we do together? As an individual, there's very little I can do. But when we have our government behind us, we can really knock on doors with greater confidence and get more help to Malawi.
And are there any plans to expand these camps to other parts of the country? Say you've been to Queen Elizabeth Central Hospital in Blantyre, you're now in Lilongwe at Kamuzu Central Hospital. Maybe say go to up north, Mzuzu, Karonga, Chitipa. Any plans?
With having a mom from Elangeni, my dad from Chileka, when people ask me, where are you from? I can say that Konse. I take all of Malawi.
Yes.
Put me in Karonga, I'll be there. Take me to Nsanje, I'll be there. And so in terms of planning, we are building this plane as we fly. The care is needed there. If there were more teams, it would be easier, but then there are other challenges: patient care, quality of care, making sure that we don't accelerate without proper care. So when we limit it so that the people on the ground who remain to provide that care really know, then we know we're not doing harm. If we have too many things going on all at once, people can suffer in the end, and we don't want to diminish post-operative care and quality.
Now, is there something that Malawi could do or needs to do to reduce its dependence on foreign supported surgical missions?
Training. It boils back to training. We need to build that center for training. When we train our own Malawians, then we don't need somebody to come from the outside. And that is what we want to do. We want to build. We've talked about building. We want to make a proposal about creating such a specialty training program so that we don't need this. We've started, there's a dental school now. The second set of dentists graduate in 2 months, but it happens little by little. Yeah.
Do you think the government is doing enough in terms of investing in training surgeons in this field at this time?
I've not had a direct conversation with the government about that. So Dr. Mjenga, who's here, has had his experiences with that. And he probably can better answer. I'm a spectator, I don't know.
When else are you expected to come back to Malawi for camps of this kind?
Well, we have ambitions to coming maybe twice a year. If we can come more frequently, then more people get care. But some of the challenges include the cost. And our teams that have been helping us have a huge bill they need to settle. And that's a place where maybe the government can help the teams on the ground to meet that need, for one, and help us to find things like accommodation when we come in. How do we take care of the people that are here? It could be simple, but right now we're in hotels and other areas because we don't have that place to go. When that gets sorted out, it's easy to send people. Then the limit becomes equipment. So we use this partnership to say, hey, Malawi does not make drills. Otherwise we'd say, please, let's just go to the store and we'll buy them. We have to go and get those drills from somewhere. When I say drills, they cost anywhere from $20,000 to $30,000. I don't have that. So with the government's help to make these appeals to say, this is a national crisis. I need to have 100 drills, 20 at Mzuzu, 20 at KCH, 20 Queens, Kuchikwawa. Then our areas are equipped. When we get equipped, then people just come, they work, they train, and it becomes easier. But it takes pangono, that's the challenge. But it can be made faster with people who can write signatures and mobilize things. Yeah.
Right, Dr. Nkungura, it's been a pleasure having you in the
Thank
program.
you so much.
Thank you so much.
Thank you. Tatokoza.
That's how we conclude the program today, Zodiac Exclusive. And my guest today was Dr. TANIA Nkungura, an oral and maxillofacial surgeon, a co-founder of the Smiling Surgeons Incorporated, a non-profit making organization based in the United States of America. My name is John Paul Kayuni. Till we meet again next time, goodbye for now.